Good afternoon. Welcome to 90 Minutes, the medical magazine of the web, brought to you by New York Medical College and Touro University. I am your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of Touro University. My, how time flies. This is our 32nd symposium, and we are coming up upon our 5.5-year anniversary of doing these programs. We, of course, launched the programs at the onset of the COVID-19 pandemic, and we devoted ourselves entirely to COVID in the beginning. And then we began branching out to become a general medical magazine of the web, trying to tackle common questions which affect healthcare providers and are of interest to patients, and we hope not to disappoint with our session today. Today, we're going to have 3 sessions tackling very common issues in medicine. The first involves screening for cancer and the issue of when do you get to be too old to be sent for routine screening with mammograms, with colonoscopies, or with PSA, prostate-specific antigen testing. We have assembled a panel of experts to discuss this. We're going to hear from breast surgeon Dr. Maria Castaldi from Metropolitan Hospital, the chief of gastroenterology at Westchester Medical Center, Dr. Edward Leibovitz, the chair of urology at Westchester Medical Center, Dr. John Phillips, and the chief of breast surgery at Westchester Medical Center, Dr. Tuan Nguyen. And we're going to have a roundtable discussion on the topic of cancer screening and those older than 70. When's enough enough? When does it no longer become cost-effective or in the best interest of patients to undergo these screening tests? Our next topic is also a screening topic. Is there really such a thing as a screening hearing test? Should people go for screening hearing tests, or should they only go if they're having trouble hearing? What about if the person says, I hear fine, it's just my spouse who's driving me crazy who says I can't hear? Well, to talk about that, we've got someone who we've had on these programs before. Greg Goldhagen, a audiologist at Westchester Medical Center, is going to tackle those topics for us. And then batting cleanup, since it's August, it's time to talk about getting that kid out of the house and off to college. Some of you are sending teenagers off to be freshmen at college. And I have, to that end, invited the professor and chair of the Department of Family Medicine, Dr. Laurie Solomon, and infectious disease specialist, Dr. Marissa Montecalvo, to talk with us about, should you take your child for a physical exam before they go off to college? How do you transfer information from your primary care doctor at home to the student health service? And particularly important, what vaccines are necessary before having a child go off to college, particularly the nightmare experience for some parents when the child goes off to college and is diagnosed with meningitis. Can we prevent that with sensible vaccinations before going off to college? This will, like our first session, also be a panel discussion. As always, if you are puzzled by some of the things you have heard or want to know more about it, type your questions in the Q&A box on your computer screen, and we will get to as many of them as possible in the Q&A part of our program at the end of the presentation by our panelists. For those of you looking for continuing medical education credit, CME credit, I will appear in between some of the sessions and explain to you exactly how to get your CME credit. We hope you find this yet another worthwhile webinar from New York Medical College and Touro University. Welcome back, and let's get started with our program. Hello again, this is your host, Dr. Edward Halperin. Welcome you to our panel discussion on the issue of cancer screening in the elderly. Now, don't get upset. The definition of the elderly is an entirely movable definition. So whatever you think elderly is okay. What we're going to be talking about is people 70 years of age and older. And we're going to be talking about the topic of cancer screening. Who no longer needs routine colonoscopy, prostate-specific antigen testing, or mammography or other breast imaging because of their age. Now, when we teach our medical students about the concepts of cancer screening, we tell them there are three fundamental principles for any screening test in medicine. Number one, you need to be looking for a disease that is common. Number two, you need to have a test which is likely to identify the disease. And number three, you need to have a therapy that can actually make a difference in the disease if you find it. If a screening test meets that three-part standard, it's likely to be successful. Let's pick two extremes on the spectrum to illustrate that point. One extreme, high blood pressure. It's common. You can detect it by measuring people's blood pressure at a routine physical examination. And if you find it, you can do something about it. You can treat it. Pick something at the extreme at the other end of the spectrum, a disease like Huntington's chorea. There is no obvious screening test. It's a very rare disease. And even if you had a screening test and could find it, there's no therapy to prevent it from occurring in someone. So it would not meet the criteria for a screening test. In the world of cancer, we are going to be talking today about three tests which concern common diseases, which can be identified, which you can do something about. Colonic cancer, breast cancer, and prostate cancer. To chat with us about this topic today, we have a panel of stars. Some of them are old friends of yours from previous webinars, and some are people you haven't met before. So we're going to start by asking our panelists to introduce ourselves. Let's take it in alphabetical order. Dr. Castaldi, please.
Thank you, Dr. Halperin. Maria Castaldi, the Director of the Breast Health Program at Metropolitan Hospital, the Health and Hospitals Corporation, and Professor of Surgery, New York Medical College.
Thank you. Dr. Leibovitz.
Thank you. Dr. Edward Leibovitz. I'm the Chief of Gastroenterology at Westchester Medical Center, Professor of Medicine at New York Medical College.
Thank you. Dr. Nguyen.
Dr. Halperin, thanks everyone. Glad to be here. I'm Dr. Tony Nguyen, Section Chief of Breast Surgery at Westchester Medical Center. Glad to be here.
And Dr. Phillips.
I'm the Professor and Chair of Urology at New York Medical College and Director of Robotic Surgery and GU Oncology.
Thanks everyone for joining us. Dr. Leibovitz, let's start with you because of the various cancer screening tests. Typically, the award winner for Americans being least compliant is getting your colonoscopy. People may be willing to stick their arm out for a blood test, and women are pretty good about getting pap smears, but signing up for that colonoscopy is usually a tough sell. And there was an article in the Journal of the American Medical Association about 3-4 weeks ago about yet another report of trying to replace colonoscopies with a blood test. non-invasive colonoscopy to increase compliance, but my reading of the article was pretty good for identifying existing cancer, but not for identifying precancerous lesions. So for everybody in our audience who's going, uh-oh, he's going to talk about colonoscopies, when are they going to get rid of those things? Let's start with that first. What's the prospect of making colonoscopies history? Or are we basically stuck with this procedure for a while?
So that's a great question, Dr. Halperin. Actually, close to the goal in New York State is to have 80% of the population screened according to guidelines, and we're close to that. Screened means by any of the approved tests. There are stool-based tests. So there's something called a FIT test, which is a sensitive test for blood. It's about 75% sensitive for colorectal cancer. There's a Cologuard test, which you probably see advertisements for. It's 92% sensitive for colorectal cancer. There, as you mentioned, a new blood test called the Shield test, which is approved by the FDA. So the Shield test is 57% sensitive for stage 1 colorectal cancer, but 80 to 100% for more advanced. And then we have colonoscopy, which is 95% plus sensitive for colorectal cancer, but also is the only one that detects with a high likelihood advanced premalignant adenomas. What I tell people is the best test is the test the patient is going to do. If the patient is not going to get the test done, it's worth nothing. We still consider colonoscopy the gold standard, but I think we have to put all of the options on the table for our patients. I think in 10 years from now, we're not going to be doing screening colonoscopies. That's just my prediction. I don't have any inside information, but I think the blood tests are going to get better and better to the point that colonoscopy will become a therapeutic test for people who are already diagnosed with premalignant or malignant lesions.
You used a word that some of our listeners are probably thinking, well, I think I know what that means, but I'm not sure I know what that means when a doctor uses it, and that's sensitive. So I guess you'd better tell the audience sensitive versus specific and what the distinction is.
So we're only talking about sensitivity here, and sensitivity refers to the likelihood of picking up a lesion when, or a positive finding when the finding exists. So it's the positive results divided by the true positives, meaning that, say, for a FIT test, if you have 100 people that have colorectal cancer, it's going to be positive 75% of the time.
Okay. And let's turn our attention to what we've convened to talk about. At what point does someone get to an age where you say, you don't need any of these tests anymore for colon cancer
So,
as a routine screening?
so routine screening is indicated to age 75 or until the point that the patient's life expectancy is less than 10 years. And the rationale for that second part is that it takes 15 years for normal tissue to turn into a premalignant adenoma and eventually a cancer and an invasive cancer. From age 75 to 85, I would use the term shared decision making. It really depends on the risks and benefits for that individual patient. So the factors that we were going to consider are the patient's prior screening history. Is this someone who's had many premalignant polyps in the past? Has he had colorectal cancer in the past? And the patient's associated medical conditions, what we call comorbidities. Does the patient have advanced heart disease or lung disease or kidney disease, liver disease, Is the patient on blood thinners that are going to increase their risk of bleeding? Is the patient very frail? So in those patients, the risks of the screening go up, of a colonoscopy, for example, and the benefits don't warrant it. So, between age 76 and 85, it's really an individualized decision.
Thank you. Dr. Phillips, in the world of prostate cancer, some of the issues are the same as the ones Dr. Leibovitz just touched upon, but the testing is a lot different. It's either a blood test for a prostate-specific antigen or a rectal exam for palpation of the prostate. And boy, has there been a debate back and forth about whether men need routine PSA testing. And if they do, at what age do you stop? So, what's your take on when is drawing a routine prostate-specific antigen blood test no longer part of routine healthcare for a man?
In general, the standard has been to look at the patient's 10-year life expectancy, and that it was thought that the magic number of 70 or 72 would be the end of PSA testing for patients. And I guess this was followed recently by President Biden's healthcare givers, and a lot of patients have been coming in asking whether or not he had had PSA testing throughout his 70s, because he eventually showed up, of course, with metastatic prostate cancer when his last PSAs were reportedly normal. And so a lot of patients are interested into what age should PSA testing be stopped. And we have guidelines suggesting what age that is. And generally, we look at a 10-year life expectancy, that if someone has high risk, African-American descent, family history, abnormal physical examination, or urinary symptoms, PSA testing is very important, even above the age of 75, especially if one has never been done. For asymptomatic men, those men who have no urinary difficulties, no family history, are otherwise healthy and understand the risks and benefits, who are 75 years of age or older, PSA testing may be deferred. Of course, this is shared decision making, as we heard from our gastroenterology colleagues, and that there are risks and benefits of doing something and risks and benefits of doing nothing. So in that sense, it's not a screening test, but strategic testing.
Dr. Phillips raises a very important point. Some people don't take seriously the idea of celebrity illness, but in cancer screening, when Ronald Reagan had colon cancer, it affected screening rates in the United States. When Nancy Reagan and Betty Ford had breast cancer, it also very much affected mammography rates. And I'm sure it's true that prostate cancer in former President Biden or former Mayor Giuliani or presidential candidate cabinet member John Kerry all has affected screening rates. Well, speaking of Betty Ford and Nancy Reagan, let's talk about mammography, Dr. Castaldi and Dr. Nguyen. Mammography kind of rivals prostate-specific antigen with competing recommendations for who needs it and when and how often and what age to start. So, Dr. Castaldi, let's start with your take. At what age is routine mammography no longer thought to be necessary?
So in taking off some of what the others have mentioned, the guidelines do increasingly emphasize the importance of the shared decision making, where the patient and the clinician do discuss the benefits and both the harms of screening in light of an individual's overall health. So having said that, there are two competing bodies of literature in terms of starting and even in terms of when to stop. So for example, continuation beyond regular screening through the age beyond 75, 70 beyond, or the age 75 for individuals in good health, while advising those aged 76 above, even through their 80s, this clearly needs to be discussed with the physician. We do know that the paramount the most clearly associated completion of screening is based on physician recommendation. So if these discussions are not had with the physician based upon when to start and when to stop, the patient is sometimes misguided.
Mhm. Thank you. Dr. Nguyen, let's talk about some nuances of breast screening. What's your approach to the patient who says, I've just listened to what the guidelines are, and I'm 83 and I want it?
Yeah, great.
Or my mother lived to 102 and don't tell me about your guidelines. I want it. And this is just the insurance industry trying to not pay for things. How does one respond to such a patient?
Yeah, great question, Dr. Halperin. And, for us physicians and other providers, guidelines serve as just that. They're guidelines, right? They serve as a general starting point to discuss with patients about the generalities of when to do certain things or treatments or tests or whatever they may be. But as Dr. Phillips and Dr. Leibovitz and Dr. Castaldi said, in cancer screening and like everything else these days, it's a lot of shared decision making. So those of us that do this on a regular basis, we utilize the guidelines as a baseline to start a conversation, and we take it into account, as others have stated, what the patient's age and medical health, comorbidities, and their wants. If and then when I talk to a patient and I ask them, look, if you find a cancer, would you want it to be treated, regardless of whether you're symptomatic or not? And if your answer is yes, I'm healthy enough and I want it to be treated, then you should probably go get screening for whatever cancer that may be. And I think from a mammogram standpoint, in terms of invasiveness, that's probably somewhere between a colonoscopy and a blood test for PSA or prostate specific antigen. So for some women, getting a screening mammogram is not that big a deal. For others, to include transportation barriers, to include psychological impact that they may have on them, to include the possibility of overtreatment, they may weigh against that. So for someone who is in fairly good health, in their 80s, and who are motivated and who are willing to treat their disease, whether or not it will lead to mortality, I generally acquiesce to the patient's request for screening
Okay.
and recommend that.
Well, thank you. Well, as usual, the time has flown by, but I want to put one question on the table for all four of you, and we'll make this the lightning round. Anybody can weigh in, most of you can weigh in. Let us assume that the patient sitting in the examining room shows up with a piece of paper and says, listen, I saw an advertisement for executive physicals, and I went out and I had a whole body CT scan or a whole body MRI because I saw an advertisement in the newspaper for a practice that says, get your whole body scan for health screening. And I did it. And they say they didn't see any cancer. So, what do I need to talk about? Screening for colon cancer or breast cancer or prostate cancer, depending on whether the patient's a man or a woman. And I wish I could tell you this was made up, but it certainly is not made up. There are advertisements for these practices selling whole body, head to toe imaging. Oh, who'd like to weigh in? What do you say to the person who waves a quote screening CT or MRI whole body scan report at you and says, your tests are old fashioned. I've already been scanned from stem to stern.
Well,
I
Dr.
could,
Halper, I would say in prostate cancer, the screening, the strategy of screening is about trying to identify those men with early prostate cancer that may be at a risk for developing clinically significant or metastatic disease. If a patient is a screening imaging study, a total body screening imaging study, and they see prostate cancer on that, it's already metastatic. And so we're well beyond the period of time to help them. If a scan is negative, it does not necessarily rule out early or low stage prostate cancer, which is generally based on a needle diagnosis, not an imaging study.
For colon cancer, a CAT scan, a routine CAT scan, is not sensitive at all for colon cancer. So it was really not an adequate screening test. Now, some of these executive health exams offer something called CT colonography. That is a acceptable screening test, generally not covered by insurance, so it's only done routinely at these executive health exams, but it is a adequate screening test.
For breast cancer, although the screening is inadequate on whole body scans and mammography still remains the gold standard, it is well known that in those women that are older, somewhat older, 70 or older, that finding a small breast carcinoma is actually one of the strongest predictors of a decline in both physical and mental health, in those domains in terms of quality of life, knowing that there could be a small carcinoma that has been diagnosed. So although the scan is negative, the age would become very important in whether or not you would wish to pursue screening with mammography.
Yeah, I agree with Dr. Castaldi. I think, as Dr. Phillips stated, for breast, when you get an MRI of the breast, it is done very differently than when you do a whole body MRI. So the screening test just really isn't that specific. It may rule out advanced disease, but it certainly wouldn't rule out early disease in breast.
Thank you, Dr. Nguyen. Thanks to all our panelists. As always, if you have questions for any of our panelists, type them into the Q&A box on your computer screen, and we will get to as many of them as possible during the Q&A part of today's webinar. Thanks to all our panelists for joining us. Hello again, this is your host, Dr. Edward Halperin, with information for those of you who wish to obtain continuing medical education credit, CME credit, for today's webinar. As usual, we have two choices for you. You can get out your cell phone and text the words 38 WAPS, all in capitals, 38 WAPS, WAPS, to 828-295-1144. If you do that, you're going to get a text message back with instructions as to how to fill out your satisfaction questionnaire for today's webinar and how to get your CME credit. If you don't like that, you can use your QR code reader on your iPad or on your cell phone. Take a picture of that funny-looking little chessboard in the middle of the screen, and you're going to similarly get taken to the website to fill out the form for satisfaction with today's webinar and to get your CME credit. Now, in either case, I suggest you get about your business and do it, because the code will expire on Sunday, August 10th at noon. So don't dawdle, and be sure to go ahead and do it if you want your CME credit. Now, maybe you want to take a screenshot, you want to write the phone number and the code down, you want to get out your cell phone and take a picture of this slide, and whatever you do, follow the instructions to get your CME credit. Now, as always, if you have a question for any of our panelists today, please type your question in the Q&A box on your screen, and we will get to as many of them as possible in the Q&A part of our program. And let's get back to our next session.
Hello, my name is Greg Goldhagen. I am an audiologist at APS ENT at Westchester Medical Center. I am going to be giving a talk today about, is a screening health hearing test part of routine healthcare, or should people only be advised to go for tests if they notice they are having trouble getting through the day? With any talk, I have to tell you that I have no conflict of interest to disclose. So I'm going to go and start the talk. So the easy answer to this question is yes, a hearing screening should be part of a routine healthcare. One of the reasons that is because hearing loss is not binary. It is not an all or nothing event. There are shades of gray when it comes to hearing loss. You can hear low frequency well, which means that you can hear people when they're talking and not hear mid and high frequencies, which gives you more difficulty understanding sounds. It is important for your health and well-being to be aware of how well you hear. This will impact your health and your happiness. Hearing loss does affect us more as we age. Hearing loss typically starts to affect people in their 50s and 60s, with it increasing in age. Age-related hearing loss, which is presbycusis, is common, but this can happen in younger people too, because there are other factors like noise exposure, certain medications, genetics can also contribute to hearing loss at any age. Approximately 1/3 of adults between the age of 65 and 74 experience some sort of hearing loss, and that goes up as we hit into our 75s, where it's at least 50%. You can get your hearing screened at a doctor's office, primary care physicians. Some of them will screen your hearing, an ENT office, an audiology clinic, health fairs, and there are some online-based screenings. I do not like the online-based screenings because you never know if those screenings are calibrated right when you're using your phone or your computer. So there are some problems with that, but it's not a bad place to start, maybe. The importance of hearing screenings. Hearing screenings are crucial to maintain health and well-being. There are a lot of risk factors as we age, as I mentioned before, and early detection and intervention can significantly improve your standard of living, your academic performance, and even your brain health by preventing cognitive decline. The benefits of having your hearing screened is, one, you're going to reduce your frustration and isolation. Untreated hearing loss can lead to feelings of frustration, isolation, and depression. Early intervention can significantly improve your overall well-being and quality of life. It will improve your social interactions. One of the most important things of staving off depression as we age is interactions with people. And it is much easier to interact with people if you're hearing well. So by treating hearing loss, it can restore your communication and social interactions, and it can give you a more active social life. Cognitive load. It will help you when you have a hearing loss. Your brain has to work harder to process sounds, and that diverts cognitive resources away from other functions like memory. Social isolation is one of the leading causes of depression as we age. And if you can't hear, you are isolated. It can also lead to some paranoia because you believe that people are talking to you, and that can truly impact your mental happiness. Social isolation is also one of the leading causes of cognitive decline. Brain changes. Hearing loss can lead to changes in your brain structure and its function, particularly in areas of hearing and memory. Slower cognitive decline. A hearing loss will, when treated, can reduce the rate of cognitive decline. There has been studies that have been out there that have shown that people who treat their hearing loss can at least slow down the rate of dementia and Alzheimer's. It is not a cure for it, and there is still research going on whether or not it is a causation or a correlation related result, but it is something that memory and cognitive function is definitely something that is affected by knowing whether you have a hearing loss or not. Thank you very much. I hope I shed some light on this. And if there are any further questions, please let me know. Thank you.
Hello again, this is your host, Dr. Edward Halperin, asking you to consider giving back to New York Medical College. The programming that you are viewing today provides free CME credit, but obviously putting on these programs don't come for free. There is the time and effort of our speakers and the considerable time and effort of the IT team to put on these webinars. We hope some of you will consider financially supporting the webinars that you're watching and the research projects at New York Medical College that underpin the opinions that you're hearing. You can help by making a tax-deductible gift to help offset our costs. Great things are happening here at New York Medical College, and we hope you'll be part of it. If you want to make a donation by phone, if you phone 914-594-2720, a pleasant person from the fundraising office will be happy to take your phone call and take your credit card information over the phone. If you're an online person, donations may be made online at the website www.nymc.edu/give. And for those of you who like to get out a checkbook and write a check with ink, you can do that, put it in an envelope and mail it to New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Please put on the memo line of the check, webinars. Thanks for thinking of us. We hope everyone stays safe and healthy. And as always, if you have questions for any of our panelists, please type them in the Q&A box on the screen, and we'll get to as many of them as possible at the end of our program when we get to the Q&A section of today's broadcast. Let's continue with our program. Hi again, this is your host, Dr. Edward Halperin, and it's time for our panel discussion regarding that teenager you've got in the house, and you're going to get him out of the house and send him off to college. What do we need to know about the medical care of the transition from high school and living at home to going off to college and living in the dormitory? What do you need to know about a medical exam? What do you need to know about communicating with the student health service? And what do you need to know about vaccines? For those of you who are long-standing fans of these webinars, we've got two of your old friends with us, Dr. Marissa Montecalvo and Dr. Lori Solomon. As I can tell from the fan mail that we've been getting over the years for many of you, it doesn't matter what the Center for Disease Control says. It doesn't matter what the FDA says. You're not getting vaccinated until Marissa Montecalvo tells you it's okay. So she's with us to talk with us about this issue. And another one of the fan favorites, America's Family Doctor, Dr. Lori Solomon, is with us. So let's start with inviting our two panelists, let's say in alphabetical order, to introduce themselves, and then we'll get into the substance of our conversation. First, Dr. Montecalvo.
Hi, good afternoon. I'm Marissa Montecalvo, and I'm the Medical Director of Health Services at New York Medical College, and I'm a professor of medicine in the Division of Infectious Diseases. It's a pleasure to be here. Thank you.
Dr. Solomon.
Thank you, Dr. Halperin. I'm Lori Solomon. I'm the Chair of Family and Community Medicine at New York Medical College, and I'm also the Medical Director of the Family Health Center.
Now, let's start our conversation with some basic epidemiology. Dr. Montecalvo Jr. has been living in the house with the family, been going to high school. Maybe they've got a summer job, and it's August. Pretty soon we're going to pack up the minivan, put all the stuff in trunks, and take them off to college. What is the basic issue about infectious disease when you take someone living in one community and send them off to mega university with 40,000 undergraduates and 10,000 graduate students roaming around on the campus and 60,000 people in the stadium on Saturday afternoon for the big football game?
Well, I think the main issue is that you're going to be exposed to new pathogens. And, college is almost like the military, right? I mean, but not quite. They're not as organized for sure, nor as disciplined. And, you're going to be living in close quarters. You're going to be socializing in close quarters. And that is a prescription for the transmission of communicable disease. And most of those diseases will be respiratory, but there certainly could be transmission of GI illnesses. People are always eating together. And I think the other big area, besides being at risk for respiratory illness, and we'll talk about those, is also sexual health. So, there's the illness that the new college student is most likely to get, if they don't already have had it, is infectious mononucleosis. And that is, transmitted by saliva, can be by sharing drinks, but is the kissing disease. And sexual health is a big part of preparing for being away as well.
Thank you. Well, Dr. Solomon, let's assume that either mom or dad or both have packed the teenager up and brought them in to see the family doctor or the pediatrician for a visit before it's time to go off to college. Let's talk, please, about what are you particularly looking for in a physical? What lab tests, if any, are you going to order? And what are the issues you want to go over with the teenager and their family before they go off to college? And perhaps while we've got you, we should also talk about teenagers with known chronic diseases that are going to have to make the transition to a new caregiver.
Okay, happy to talk about that. One of the things that I love about family medicine is I don't have to say goodbye to my patients. So if your son or daughter is with a pediatrician, they will need to consider transitioning over to a doctor who can care for them in their adult years. So this is the time to switch from the pediatrician to either a family physician or an internal medicine doctor who is familiar and comfortable with managing adult illnesses. There are some pediatricians who will continue to see people through college, but it's best to start the transition when they're transitioning from childhood to adulthood. It's best to move physicians. But for physicals, we generally do a risk assessment. So we're mainly doing a history to find out what behaviors the patient is engaging in. So we talk about sexual health, we talk about healthy lifestyles, we talk about substance use, we review vaccines. Are they up to date with their vaccines? And I think Dr. Montecalvo will be talking about that in a little bit. And then we go through any preventative care that needs to be done. There's very little screening that we need to do for somebody at the age of 18, but really we are looking at mostly risk factors. In terms of labs, very few labs are actually needed at a 17 or 18-year-old well visit. So it really just depends on whether they have any chronic conditions or have any outstanding needs that we need to check on. For students who have a chronic condition, it's really important that the patient and the doctor and family come up with a plan for how to manage those chronic conditions while they're away at school. So who's going to be the point person? Do they need to have a provider up at the school to manage that, or whether, or can that be managed through a televisit? What would be that, do they need to schedule a follow-up appointment when they come home on break for their chronic condition? Make sure that they have enough medications up with them at school, and if they don't, how are they going to get the medications? Are we going to transfer the prescription to a pharmacy close to the college, or are mom and dad going to be sending the medication in a care package? The other thing that I generally talk to patients about who have chronic conditions is a plan for managing acute exacerbations of a chronic condition. So, what would they do if things start to go downhill? And having that plan figured out ahead of time makes all the difference in the world. It really saves them from going to the emergency room if they can help it. And so, so having all of those things in order, and then the question is, do you need to let student health services out on the college campus know about the chronic condition? It really just depends on what it is and the acuity.
Lori, do you have any advice for parents about the conversation with their child about selling of medications on college campuses? Unfortunately, relatively common issue is, you want to buy some of my pills for attention deficit disorder, you're going to do better on the final exam if you take these. And many universities have to deal with students deciding to take their prescription bottle and go sell their pills to the classmates because, quote, it'll help you get an A. Any thoughts about advice for parents on this issue?
I think this kind of falls into a big basket, a basket that I call setting your expectations. Discussing your expectations with your students. So I think that every parent has expectations of how they want their child to behave while they're at school. And so, if they're on a prescription medication, they should be talking about their expectations for how they're managing their medications. Where are they storing them? How are they taking them? Do they need to set up a reminder on their cell phone? And then obviously the expectation that they aren't selling their medications. That would, just letting the student know, this is what we expect. We expect that you're the only one taking your medication. You're not sharing it with anyone. And then kind of explaining why that's important, and the fact that selling a controlled substance is illegal. Just letting them know that. But then I think other expectations around drinking, smoking, drug use, sexual activity, healthy lifestyles. These are all things that you should talk with your student about before they leave for home. The studies show that it does make a difference. If the student knows that the parents are expecting a certain behavior, they're more likely to do that behavior.
Yeah. Thank you. Dr. Montecalvo, let's talk about vaccines. Unfortunately, a not uncommon story was she seemed fine in the morning. She complained of a headache, and by that evening, she was at University Hospital in the ICU because of meningitis. What happened to my kid? I sent him off to college, and now look at this. So, what should be on the list of vaccines for going off to college? In particular, your thoughts about vaccines for meningitis before you send someone off to college?
Yes, thank you. So Meningococcal infection is, as you've already said, is very serious. It has, it's a bacteria, and it has a mortality of 10 to 15%. And for those who survive, there's about 20% who have long-term disabilities, either from the clots that occur in the hands and the feet or kidney failure. So it's a very, very serious disease. Is it a common disease? No, but it is important to prevent it. It's extremely important to prevent it, and it's particularly important when teenagers and young adults are going to college, where they're going to be in a close setting, because meningococcal disease is a respiratory infection. We don't think of it that way because it's meningitis and it's a serious bloodstream infection. But the way you get meningococcal meningitis is inhalation from someone who's a carrier in close proximity to you. It colonizes the back of your throat, and if it is one of the invasive strains, there are many strains of this bacteria, but if it's an invasive strain, it will gain access to the bloodstream and then can result in meningitis. But this is a respiratory infection. You don't have respiratory symptoms. You don't feel it when you acquire it in the back of your throat, but it's a respiratory infection. And vaccination, I think, is essential. You can't uh, cut short prevention when it comes to things that have serious ramifications. And there are a few diseases as serious as meningococcal meningitis. There are a few things that can kill you within the space of 24 to 72 hours, and meningococcal meningitis is one of them. So vaccination is very important. Just quickly on the vaccinations, so it's a little confusing because there are 5 strains of this bacteria that are invasive. They go by letters, A, C, W, Y, and then there's B. So we started out with a vaccine that covered ACWY, and then the vaccine for B was developed. And as of 2023, there is now a vaccination that has all 5 strains together. Many children are vaccinated in preparation for camp because that's a close contact situation. So this is something that you really have to, that when you go to that pre-college assessment with likely your pediatrician, if you're lucky, your family doctor who will continue to see you, you want to go over what was done, what have they received, what do they still need, because there are caveats in terms of mixing and matching those vaccines. In general, it's a 2-dose series. There are people who are at higher risk for this infection, people who don't have a spleen, either because of a perhaps surgery or having sickle cell disease, or some people on biologics can be at higher risk. So that's all information that needs to be reviewed with your physician. But the general healthy student going to college still needs meningococcal vaccination.
Thank you. Thank you to Dr. Montecalvo. Thank you to Dr. Solomon. As always, if you have questions for either of our panelists or questions for any of the panelists at today's webinar, type them into the question box on your computer screen, and we'll get to as many of them as possible during the question and answer series of our program, part of our program today. Thanks to our panelists, and we'll see you in a moment with our next program. Hello again, this is your host, Dr. Edward Halperin, with information for those of you who wish to obtain continuing medical education credit, CME credit, for today's webinar. As usual, we have 2 choices for you. You can get out your cell phone and text the words 38 WAPS, all in capitals, 38 WAPS, WAPS, to 828-295-1144. If you do that, you're going to get a text message back with instructions as to how to fill out your satisfaction questionnaire for today's webinar and how to get your CME credit. If you don't like that, you can use your QR code reader on your iPad or on your cell phone. Take a picture of that funny-looking little chessboard in the middle of the screen, and you're going to similarly get taken to the website to fill out the form for satisfaction with today's webinar and to get your CME credit. Now, in either case, I suggest you get about your business and do it, because the code will expire on Sunday, August 10th at noon. So don't dawdle, and be sure to go ahead and do it if you want your CME credit. Now, maybe you want to take a screenshot, you want to write the phone number and the code down, you want to get out your cell phone and take a picture of this slide, and whatever you do, follow the instructions to get your CME credit. Now, as always, if you have a question for any of our panelists today, please type your question in the Q&A box on your screen, and we will get to as many of them as possible in the Q&A part of our program. And let's get back to our next session. This is your host, Dr. Edward Halperin, and there are a lot of questions that have come in today for our panelists. Let's see if we can get to as many of them as possible. We're going to start with Dr. Edward Leibovitz, please, if he could turn his camera on and turn his microphone on and join us. Dr. Leibovitz, the first question that came in this afternoon is, what's your view on the status of screening tests for pancreatic cancer? We know you were here to talk about colon cancer, but the listener wants to know about pancreas cancer.
Right. So that's an excellent question. It's a area that is very needed because currently most patients who are diagnosed with pancreatic cancer are already at the stage that they are not curable. So for pancreatic cancer, if a patient is at high risk due to an underlying condition or a strong family history or a genetic risk factor, while there is no guideline that demands this, I think many of us will do surveillance by doing MRI, MRCP, and certain blood tests like tumor markers, CA19-9, CEA, on a regular basis. I do it every 6 months on patients who are at high risk. What we are looking for is early changes that would be at a stage that we can intervene. I mentioned when we talked about colon cancer, the blood test that was recently approved for colon cancer. This is in the whole area called liquid biopsies, that are blood tests that look for aberrant or abnormal DNA circulating that can be associated with cancers of many different sites. And there are such tests on the market now. You get a blood test and it'll identify and say, you should have further evaluation looking at your pancreas or looking at your prostate. These are not FDA approved. They are pricey, but they are available. It will not make a diagnosis, but it will at least bring you to attention that that area needs some, close evaluation. As I mentioned before, I think, in 10 years from now, we will be screening for a variety of cancers with liquid biopsies, but we're not there yet.
Can you tell us a little more about how you decide who's at high risk? for pancreas cancer that warrants this? I can imagine our listeners saying, well, that's all good, but how do I know if I'm in that group?
So patients with advanced chronic pancreatitis, I'll mention that paper in the New England Journal is actually authored by a surgeon here at New York Medical College, Dr. Lowenfels, that showed the strong association between chronic pancreatitis and pancreatic cancer. Certain genetic syndromes, such as BRCA, are at high risk. There are certain medical conditions like primary sclerosing cholangitis, where we monitor mainly for cholangio or bile duct cancer. But, at the same time, we'll be looking at the pancreas. So it's really genetic syndromes, a strong family history, and chronic pancreatitis are the ones that are most commonly going to be.
Thank you. While we have you with us, let's go to another question that was typed in for you. Our listener wants to know, what are your views on screening for colon cancer by swallowing a small camera, which can then traverse the GI tract and send back pictures?
So the questioner is referring to a device called a pill cam. So the pill cam has really revolutionized visualization of the small intestine, which is not a common location for cancers, but most commonly used to evaluate bleeding. And it gets a very good look at the small intestine because the caliber of the small intestine is much smaller than that of the large intestine. There is now a pill cam that is designed for visualization of the colon. It is not FDA approved, except in the situation where a person fails a colonoscopy or is unable to have a colonoscopy. They claim a high sensitivity, there's a high rate of picking up lesions, I believe around 85%. But frankly, I find that hard to believe. Having seen these exams, you can't control that pill cam. It's just flopping around as it passes through the colon. As such, I think it's going to be prone to mislesion. So right now it has limited viability. There's actually work being done on a steerable pill cam that I think would have much more promise.
Thank you, Dr. Leibowitz. Let's give you a break. Let me ask Dr. Wynn to come on and turn his microphone on, along with Dr. Castaldi. Well, you two have set the record for numbers of questions that have come in. Let's get to a couple of them. And why don't we'll do this in alphabetical order and opposite alphabetical order. We'll let Dr. Castaldi go first on the first question, Dr. Wynn chime in, and then do the reverse for the next question. So the first question, Dr. Castaldi, is screening mammography effective for lobular breast cancer? The viewer is making a distinction between lobular and infiltrating ductal carcinoma.
Thank you, Dr. Halperin. So yes, the lobular breast carcinoma can be detected on mammography. There can be some difficulty, although these specific type of cancer, although not entirely uncommon, does not generally appear, doesn't present as a lump or a mass, which is much more easily seen on breast imaging. So as lobular breast carcinoma has very subtle changes, it can be somewhat difficult to find on mammography.
Thank you, Dr. Wynn.
Yeah, thanks, Dr. Halperin. Yeah, I agree with Dr. Castaldi that lobular cancer subtypes accounts for about 10% of all breast cancers. They are harder to detect on mammography, but we often do find them on mammography. What I recommend is that patients get mammography in centers that offer 3D mammography. still offering 3D versus 2D. Most centers now in the United States are offering 3D mammography. Types of mammogram do have a higher sensitivity rates at detecting all cancers, including lobular subtypes. MRIs are a little bit better, but those are for selected individuals who are at high risk.
All right. Well, you've offered a good segue into our next question, Dr. Nguyen, and the person writing wants to know, you folks didn't seem particularly keen on whole body MRI for cancer screening during your panel discussion, but what is the role of specific breast MRI for screening for breast cancer? So let's Dr. Nguyen go with that first, and then Dr. Castaldi can offer the color commentary to the play-by-play.
Yeah, no, great question. So huge body of literature and evidence and modern practice regarding breast MRIs. It's a very controversial topic. Ideally, breast MRIs are used for patients who are detected at high risk for developing breast cancer. So the average woman has about a 13% chance of developing breast cancer in her lifetime. We have mathematical calculators and just maybe basic questions like family history that can identify women who are at high risk for breast cancer. So if you are high risk or above 20%, most patients should have a discussion with their doctors about a breast MRI. We don't typically just use them in anybody. Mammography still is the gold standard in screening. But so MRI, breast MRI does have a role, a very specific role. And there's a lot of controversy around, that. But I'm for using breast MRIs, particularly in patients who are at high risk of developing breast cancer. And usually I don't recommend substituting breast MRIs for mammograms, which patients are often asking to do.
Dr. Castaldi, anything to add?
Thank you. No, I agree with Dr. Nguyen completely. We do use our MRIs for high risk based on history, prior diagnosis of high risk breast lesions. And unfortunately, the cost, it remains the most significant barrier for obtaining MRIs. Thank you.
Understood. Dr. Castaldi, we have a physician who has written in the following question. Given that there are different guidelines by different societies for the same cancer, for example, the United States Preventive Task Force recommends biennial screening mammography for 40 to 74-year-olds, but the American Cancer Society suggests annual screening starting at age 45 with no upper age limit. How do you pick which guidelines to follow?
So again, it's not easy, and these really are discussions that one must have with a physician regarding risk, benefit, harms. There are harms with going down the route of screening, whether it be after a certain age, whether it be annually, risks of then continuing with further procedures, risks of those particular procedures, and even risks of false negatives. So unfortunately, we have to look at age, we have to look at risk, and we do have to look at what the patient, what the benefit to the patient, and what the patient's expectations are for receiving routine screening. Thank you for the question.
Thank you. Dr. Nguyen, anything to add?
Yeah, no, again, agreed with Dr. Castaldi on this. So yeah, it's a very controversial topic. One that perplexes a lot of our frontline providers and family practice and OBGYNs. So as stated, there are several different guidelines, but by far and large, the vast majority of medical societies recommend screening starting at the age of 40. A couple of organizations are recommending maybe 45. The United States Preventive Service Task Force recently lowered their age from 50 down to 40 with an option of screening every other year. So 40 for me is just sort of an easy answer for your average risk individuals. Remember that most of the life years lost in breast cancer are in the age group of 40 to 50. So more cancers are detected later, but the people who have most years of life to lose is in their 40s and 50s, 40 to 50. So that's why I recommend screening at the age of 40, despite there are some perceived overdiagnosis or harms from multiple biopsies. But you got to ask yourself, would you rather have a biopsy or miss a cancer?
Okay. Let's do one more breast cancer screening question, and then we'll give the two of you a break for a while. The questioner writes in, I suppose we'll let Dr. Nguyen start with this one because it's kind of a variant of what we talked about in the panel. Is it acceptable for a woman to get referred for a mammogram after age 75 if she both requests it and would accept treatment if something is found? And the questioner also offers a flip side. If a referral for a mammogram is contraindicated, could you review the reasons why a mammogram would be contraindicated?
Yeah, I mean, kind of complex question, but I'll try to simplify it. In asymptomatic women who still have generally a healthy life, about 10 or more years of life expectancy, and it's hard for us to tell who has life expectancy of, a certain number of years, but generally in good health, no matter the age, and the patient is willing to accept treatment if something is found, she should generally be recommended for screening for that treatment. A mammogram typically is not invasive, so the harms, again, you could argue overdiagnosis, but as you stated, treating blood pressure is also comes with some risk. So generally, if a woman is in fairly good health and she's motivated to get treated if something is found, she should be recommended to undergo mammography screening. And what was the second part of the question? I can't remember.
If a referral for a mammogram is contraindicated, what would be reasons for a referral for mammogram being contraindicated?
Well, one is if the woman or the patient does not want one, does not want to have a referral done, and she understands her risks. Number two, if the patient has enough comorbidities where she is not expected to live more than 5 years per se, I would say that that's probably an area that I would say probably not likely to benefit her, even if something was found.
Thank you, Dr. Castaldi. Anything to add on that?
Nothing to add other than specifically to the question over 75. If the woman is willing to be treated, if there should be a finding, absolutely. And if life expectancy is considered and considered substantial, absolutely the woman should be screened and offered screening. Thank you.
All right. Thanks to Dr. Castaldi and Dr. Nguyen. We'll give you a break. You can turn your cameras off and microphones off for a few minutes because we've got someone who's got a follow-up question for Dr. Leibovitz. They're not prepared to let him off the hook about the screening for pancreas cancer. This questioner wants to know, what about someone with small pancreatic cysts? Do people with pancreatic cysts require frequent MRIs? And if so, at what age would you start doing them?
Okay, so this is a really big area. Pancreatic cysts are frequently, something like 15% of imaging studies will pick up incidental pancreatic cysts. Some of these cysts, by virtue of their features on imaging, can be identified as cysts that have some malignant potential. And this, depending on the size and the features, such patients may be recommended to have sampling, which is done by endoscopic ultrasound, which means an endoscopy is done with a special scope that has a ultrasound device on its tip and will allow the endoscopist to puncture the cyst and suck out some fluid, which is sent for analysis. And so some people will have that recommendation. Others will just be put into imaging surveillance. Again, this is based on the features of the cyst that may lead the a physician to suspect that it may be pre-malignant or even malignant. Obviously, this is a minority of the cysts because 15% of the populations walk around with these cysts. They're not all at risk for pancreatic cancer. There is a whole protocol of how to do surveillance on these cysts, which is usually done by imaging depending again on the features, every 6 months to a year. And if there is no change, in most cases, can be discontinued after 5 years of observation. But there's a lot of details to this, and this is something you need to consult with an expert on.
This is really something which has become an issue in medicine because of the prevalence of scanning people. Before people had all these CTs and MRIs and ultrasounds, people blissfully went through life. They never knew they had it. It didn't bother them. They didn't bother it, right? I never realized how common these were till when I was a resident. We were required to be on the pathology service, and you do enough routine autopsies, you realize how common these cysts are, but they're a diagnosis for most people. They're not a disease. The patient will not be diseased by them.
There was a really interesting editorial. It was an op-ed in the New York Times several years ago about somebody who was put in surveillance for such a cyst, describing the patient's perspective of all of this, which I think is very informative. The person says, I was not told that I have this dreaded disease, but I was not told that I'm in the clear either, and I'm under surveillance. And it is very rattling to people. But, fortunately, in the vast majority of cases, it doesn't amount to anything significant. And I think there are many situations in medicine where we put people under surveillance, but have to give them reassurance that it's a precautionary approach that in most cases will not lead to any bad outcome.
Thank you. We'll give you a break again. Let's put Dr. Phillips in the question and answer chair, please, if he could join us. Dr. Phillips, our questioner wants to know your views on personalized medicine and screening for prostate cancer. They continue, are there buccal mucosal swabs or blood tests to identify people at higher risk for prostate cancer, who therefore might merit more aggressive, more frequent use of PSA?
Thank you so much for that question. So worldwide, the most common test is a PSA and digital rectal examination, but there are additional screening tools that can be used to further increase the certainty of whether that PSA test is accurate. One of which is looking at different forms of PSA. This is a test called a 4K score. It statistically is much more predictive than just the PSA alone. And for those who don't wish to have their blood drawn, there's a urinary-based test that looks at the DNA and RNA signature of discarded cells in the urine that can supposedly increase the detection rate for meaningful or clinically significant prostate cancers. These are, of course, only interpretable in context of the patient's overall life expectancy, their overall health, and whether or not they have any urinary symptoms. For some patients, under the guidance of their urologist, they may also benefit from imaging. As you know, mammography is probably one of the cornerstones for assessment for breast cancer. And now prostate cancer, MRI is now becoming one of the cornerstones for the assessment for clinically significant prostate cancers. And in fact, now we are using MRI itself to help us target lesions that require more specific prostate biopsy, when in the past we weren't really using any imaging at all to target specific lesions. So thank you for your question, but that generally shows you that there are different kinds of blood work tests, urinary tests, and imaging tests that can be done to increase the confidence that someone does or does not have a clinically significant prostate cancer. And thank you.
Well, we've got some follow-ups for you as you've been speaking. Well, they really want you to answer the question about the buccal mucosal swabs to detect someone who might be at genetically higher risk or blood tests. You talked about various screening tests. Is there something that you can do to a person to say you are genetically at higher risk for prostate cancer and get put into a decision tree of more aggressive screening, whether by MRI or PSA or
Sure. Well,
right? Yeah.
Thank you for that question. So we do know that men who do have a BRCA1 and a BRCA2 mutation, if they do develop prostate cancer, may have a more aggressive form of it. But the BRCA1 and BRCA2 mutations do not necessarily mean that they are at any increased risk of prostate cancer compared to people who are BRCA1 or BRCA2 negative. Another very uncommon subgroup is in the African American community who have the gene androgen receptor variant 7 or ARV.7. And this group may have a more aggressive form of prostate cancer, but really represents a very small percentage. We are not really using buccal mucosal swabs for DNA to identify people who are at higher risk of developing prostate cancer or those who have prostate cancer have a more aggressive form. We sometimes use buccal mucosa DNA swabs to confirm the identity of the patient genetically to ensure that a prostate biopsy matches perfectly, to ensure that the patient's samples match the patient themselves. But that's not being done for a prediction.
Okay. Someone has typed in, may we have your thoughts on exosome urine tests versus PSA screening?
So Exosome DX or ExoDX is a truly non-invasive option for assessing somebody's risk of clinically significant prostate cancer. As the writer may know, many prostate cancers are clinically insignificant, which means that they can be safely watched and have no potential harm on the patient's life expectations. Clinically significant prostate cancers are the ones we need to diagnose better and potentially treat. The Exosome DX or ExoDX test is marketed to detect clinically significant prostate cancer. It gives you a score of 0 to 100 and therefore requires some interpretation because it's giving you a mere probability. It's not like a pregnancy test, which is either a yes or no answer. It's a risk assessment from 0 to 100. They believe that anybody who has a risk of 15% or greater really should have a discussion with the urologist that test potentially is positive and may require further testing. Whereas a value of 15% or even 10% or lower may be within the low risk zone and can merely supplement a low risk assessment going further. Yet it is not a replacement for PSA. So the patient will have to unfortunately have a discussion with the urologist or primary care provider about having at least one blood draw, which of course means a venipuncture, which is a relatively invasive test. Thank you.
Thank you, Dr. Phillips. We'll give you a break. We'll put Greg Goldhagen on the screen next, please. If you could turn your camera on and your microphone on. The person attending the webinar wants to know your thoughts on emerging treatments or therapies for tinnitus, even though that wasn't your topic this afternoon. Now, that's a big topic, and we have some other questions to get to, but let's sort of make this the lightning round. A brief overview of therapy for tinnitus, please.
So tinnitus is definitely not my area of expertise. There are some things that are coming out about tinnitus at this point in time, and there is tinnitus retraining therapy that you can go, and that's a lot of biological training. There are some medicines. There's also a new machine out, a new therapy out called the linear machine, which has shown some promise. It is something where they pair some noise in your ear with an electrode on your tongue that has shown some efficacy in getting rid of tinnitus. Tinnitus is really, really difficult in terms of getting rid of because the underlying cause is something that we can't get rid of.
I suppose the important message is it's a brain issue. It's the brain replacing missing sound, and our understanding of the complete mechanism of action is as yet incomplete. Would that be fair to say?
Very, very fair to say.
Yeah, is I think one can offer some hope, though. There are, through interventions, cognitive behavioral therapy and others, ways of people becoming habituated to it. Unfortunately, for some people, it just seems to fade away over time or fade away and then come back. So,
Yeah, yeah. I mean, the people who are really need to seek help for it are the people who feel that tinnitus is affecting their whole life. There's a lot of people who come in and go, "Yeah, I have some ringing in my ears. Yeah, I hear some sounds, but I can live through it." When it starts to take over your whole life, it's time to look to do more, to find some cognitive behavioral therapy, to find some tinnitus retraining therapy, to look into this linear machine. Um, uh, but that's a small percentage of people who do have tinnitus in their ears.
mhm. Well, thank you. We'll give you a break. We've got some challenging questions for Dr. Solomon and Dr. Montecalvo, if the two of them could come on. Uh, I've never failed to be amazed by the breadth of thought given by our listeners to these webinars. Let's start with you, Marissa. The questioner wants to know, are there people with certain immunosuppressive states wherein it is simply too risky to go to college and be exposed to those large number of people that Dr. Montecalvo talked about?
Well, immunosuppression is a large basket, right? There's natural immunodeficiencies, and then there's medication induced. For the most part, people should be able to go to college. They should have their vaccines. Things should be put together. But could there be a situation, particularly something like ongoing maintenance chemotherapy or something that would lead someone to really physically, mentally, or emotionally not be able to do it? Sure. I mean, that's a question that really has to be addressed with the person's primary care provider. But in general, when young adults are ill, you do everything you can to keep them in as normal a situation as possible.
Dr. Solomon, the questioner has an aspect of the same question for you. They write, are there any medical contraindications outside of immunosuppression that would say this child should not be sent off to college?
I'd say there's probably very few medical contraindications for not attending school. The one that I would think would be most relevant would be severe psychiatric disease. So somebody with uncontrolled schizophrenia or severe depression, where it's just not, it's just too dangerous to not have them supervised closely. But those are really the only ones that I can think of that would be an a contraindication. And luckily, those can generally be can be managed and controlled so that the student can attend college eventually. Sometimes, when somebody's sick, they just need to postpone until they get their disease under control, and then they can go back to school.
Fair enough. We have a questioner, Dr. Solomon, who goes sort of to the heart of your presentation during the panel. If you've been well your whole life, is it really necessary to go see the doctor before going off to college? They're questioning the premise of the go off to college visit with the primary care physician. Why can't you just pack your trunk and leave?
Well, you can do that. That is an option, and I think people do that. But I think that you're missing the point of doing some of the risk assessment screenings and some of the preventative counseling. So even if you're healthy and you've been healthy your whole life, there may be some health behaviors that you're doing that may actually impact your health in college. And as well as that, just making sure that you're up to date with your immunizations. So you may have been healthy all your life, but if you need a meningitis vaccine, you need to be in our office so we can give it to you.
Well, I hope our listener is leaving. That's probably not a good idea to pack up the trunk and just leave. At the very least, you want to be sure to get your vaccines. And well, we heroically got to almost all of the questions we were asked, but not quite all. But the time has reached 1:30 Eastern Time, and our time is up. I want to thank all of our panelists for participating in webinar number 32. As I said, this is our 5.5-year anniversary. We will see you next time with webinar number 33. We hope you have found these instructive and enjoyable. On behalf of New York Medical College and the Touro University System, thanks for joining us. Have a good rest of the day, and we will see you next time. Bye-bye, everyone.